This is Heart Rhythm TV, and I am joined by two amazing genetic specialists, Arthur Wilde from Amsterdam and Chris Semsarian from Down Under from Sydney, to talk about this brand new consensus document, an expert consensus document entitled The State of the Art on Genetic Testing for Cardiac Disease. Welcome and congratulations.
Thank you very much.
How does it feel to be out from Down Under?
Well, we locked the gates of the country about 2.5 years ago, so this is my first trip outside of the country. So it's fantastic to be here, and these guidelines are amazing. I mean, it's 11 years in the making, and I'm very excited about them.
So this is endorsed by 4 societies, led by Dr. Wilde and you as the first 2 authors, 27 authors, multiple reviewers. This is a big one, and as a clinician, genetics is becoming a greater and greater part of our role in terms of how we diagnose and how we treat patients. What do you want people to know about this document? There's some great hearts in terms of the presentation of what to do, what to consider, and you really take people through in each disease and paint the picture of what the latest mutations are. But what do you think are the most valuable, Arthur?
So what I think is that there is a lot of change since the 2011 document, and the main changes are there's other ways of genetic testing. There are many more genes identified, and it's also important to realize that many genes that have been identified in the past few years appear not to be that clearly associated with specific diseases, and that is all sorted out in this document. So we hope that the bigger the better idea about these genetic panels will stop. We have to go back to the real genes that are associated with specific diseases. And that is what this document is all about. And
there's a great table, and congratulations, where you talk about the utility for diagnosis and prognosis with different plus signs. And obviously for long QT, it's useful for both the most. And then when we get to things like atrial fibrillation, maybe not as much. Can you talk about the latest on the genetics of AFib, which is obviously, you can't be at Heart Rhythm without talking about AFib.
Yeah, no, atrial fibrillation is obviously an ongoing target. It is, and the genetics of that is fascinating. But there are a few genes, and there are, I think, a bit to our surprise in the cardiomyopathy field, genes that may lead ultimately to cardiomyopathy. They seem to present early with atrial fibrillation. Yet, I don't think genetic testing has a big role as of yet. So we never gave it a green heart. We gave it a yellow heart, which is a class 2 recommendation if you want. And the reason for that is that, and it's also not that relevant to screen family members for that. And I think you should limit genetic screening in atrial fibrillation to young people with apparently isolated AF or in combination with.
And how young is young, Arthur, for
young as
clinicians?
Below 40, 50. I'm not sure we specifically specified it, but that is the age range. And obviously when there is a family history of atrial fibrillation in young individuals.
You know, there's a lot of conditions, ARVC, Brugada, where the statistics are still that 20 or 30% will be genotype positive, like SCN5A. What is the other 70%? Do you think it's a misclassification, or we just don't know yet? Something we're not testing? Just in general.
I think it's likely to be a combination of things. I think there's some instances where there's genes we just don't know about in 2022. There are likely to be different mechanisms of the disease, and we bring this out in the document this year, because we previously focused on single mutations leading to disease, but now we've introduced the concepts of polygenic disease, where a combination of genetic variants might lead to disease, and that might explain some of the unexplained sort of cases. I mean, just dovetailing off what Arthur said, I mean, the purpose of this document is to ultimately improve the care of patients, if there's an ultimate goal. And the way we're doing that is by showing how genetics can impact on diagnosis, on treatment, and also give us information about prognosis in these conditions as well. And so it was a long journey of almost 2 years of putting this document together, but we hope that it's going to globally impact in terms of care of families.
And it is global because of all the societies that are involved with it, and for clinicians like me, reading through every one of them, it's such a great primer. It's almost written almost like it's a board review to be able to say, this is the disease, these are the mutations that we know. Yeah. And it goes, and what's really critical is it's not an EP document. This is for cardiology. This is for cardiac diseases. Yeah. And dilated cardiomyopathy spans all the way across heart failure. You want to talk a little bit about some of these new Titan, these lambda mutations and dilated cardiomyopathy? Who do we test for these non-ischemics?
Yeah, I'm happy to start answering the question. And I mean, you've pointed out a very important thing. I'm not an electrophysiologist myself. I'm a general cardiologist interested in genetics. So this document is for everyone. It's way beyond just EP. We cover cardiomyopathies, we cover arrhythmia syndromes, and new to the document this year is the congenital heart diseases as well. And so things like the example you used of dilated cardiomyopathy, I mean, if you've got a phenotype which suggests a dilated cardiomyopathy and you've looked for all the traditional causes like coronary artery disease, hypertension, thyroid disease, alcohol, and they're negative for all those things, you need to start to think about it, familial disease and genetic testing. The document also highlights the importance of a family history, which I think we're pretty poor at doing it sometimes. We'll leave it last or leave it for a quick sort of evaluation at the end of the consultation. So family history is really important, and the importance of genetic counselling as well. So to make sure that the patient knows exactly what tests they're getting done, why they're getting it done, what a positive result means, what a negative result means. And we have a lot of nice flow diagrams in the document as well, which we hope will make it simpler for the clinician who doesn't want to read too much.
It's visually very friendly.
Yeah,
and you've done a great job with that.
That's the idea.
Now, a couple practical questions from a clinician. And first of all, in Arizona, we started doing genetic testing on anyone with non-ischemic cardiomyopathy and VT, particularly those with like septal scars, the mid-septals, and we've picked up 2 Titans, 2 Lamans, and a Filament in literally 6 months.
Yeah.
So the more you look, the more you find.
Yeah.
And this is becoming increasingly relevant for when you refer someone to heart failure and say a VT ablation is not going to help you. I have 2 really important questions that could be useful for me. Number one, without getting really into commercial interests, are all genetic tests kind of the same? How do you choose a vendor? And we don't need to mention specifics, but is there importance, or do all of them pretty much do the same thing?
I'm not used to work with vendors because in Europe, at least in my country, it is limited to the academic centers where the genetic tests are done. So we choose our own panels.
I see.
And we definitely change. For example, for Brugada syndrome, we nowadays only screen SCN5A, and that is, I think, what needs to be done. And so if you are offered the panel with 30 genes, I wouldn't order that anymore. I would just order SCN5A for Brugada syndrome, because the other variants and all the other genes just mess up things. They are not helpful for the patient, they are not helpful for the doctor, people get nervous about it, and just stay to SCN5A. So the vendors that take that approach, I would prefer them compared to what I referred to earlier, the bigger the better panel. That's not the way to go. And that was in the past 20 years.
I see. So just because there's more offerings doesn't always mean it's better.
No.
Sometimes there's more uncertainty and you don't know what to do.
For Brugada syndrome is most specifically exemplified because there's only 1 gene left. But in long QT syndrome there are now 8 genes. Hypertrophic cardiomyopathy there are not 50 genes, and there's no need to screen that all. With current technology, you can still do the whole panel, but then report only on SCN5A and not on the other genes.
What do you tell a patient that shows up with nothing pathologic or pathogenic, but there's a variant of unknown significance, the VUS? This happens not infrequently. Yeah. How do you counsel that person?
It's an increasing problem because people have their genome screened on a commercial basis or in a research setting, and you end up with variants of unknown significance. And then if that variant is in a gene that has a clear association, so one of the strong or definite associations with whatever disease, then you should, I think, screen for that particular disease.
It probably is relevant.
Yeah.
It's just not clearly implicated.
Yeah.
Well, it could go either way. So a variant of uncertain significance over time could become pathogenic or likely pathogenic with more knowledge. But it could also go the other way, where it's a benign variant, it's more common in the population. So they really are in what we call genetic purgatory, where we're not sure which way they're going to go in terms of positivity or negativity. Just referring to vendors and the issue of panels and things, I think a key aspect is interpretation and classification of the variants. So if I did a gene test on you of 150 cardiac genes, there'll no doubt be variants in your genetic makeup as well. But it's that knowledge of deciding whether that variant is relevant or not relevant is really important in every genetic test that we do.
It seems like it'd be great to have a VUS global registry that when you get one, you just put it in, something that was global, and then we can start understanding.
There are. For
yeah.
specific diseases, there are already.
Yeah.
It'd be great, something that Heart Rhythm should promote as well.
Absolutely.
And the last question would be, where are we with gene editing? I know the last paragraph of this document talks about future. Where are we with gene editing? Obviously not as easy for something that's polygenic or...
Yeah. Well, I could start by saying we are curing these diseases, but we're curing them in a dish. Where we can use genome editing techniques like CRISPR to change the mutation to the normal variation. I think we're a way away from doing it in human populations, but it's a very exciting technology and a lot of promise.
Well, this is an incredible document. Congratulations. It's been 11 years since we've had an update, and it is very relevant to every clinician that sees patients with heart failure, with patients with arrhythmias, AFib even, that have a family history or are young. This is an incredible must-take, must-read document, and I've absolutely loved it. Congratulations to the authors. Thank you for joining us. Happy reading.